Thank you very much. It's a great pleasure to be here. Thank you for the invitation. So it was my job to give you an overview of the Cll genome. So that's what I hope to do in the next 15 minutes. I have no conflicts to disclose. So what I'll do is give you a little bit of an introduction to try and set the scene for the talks you will hear over the coming days. And I'll use some unpublished data from my lab on the UK Cll4 trial to introduce you to some of the key genomic features of the disease. And hopefully I'll then tie it together with some meaningful conclusions. So as I say, the Cll4 trial is quite important, particularly given that Professor Kotowski was just mentioned and it was his trial. And I'll use that trial to introduce you to some of the features of the disease. So the UK Cll4 trial randomized 777 patients to 3 chemotherapeutic arms between 1999 and 2004 and was published in The Lancet in 2007. And data from that trial has now been published in more than 30 papers. And why is that? Because of the protracted nature of the clinical follow-up and the expansive characterization that has been performed on this particular set of data. Of course, what I'm going to talk about is an unpublished series of nearly 500 patients analyzed with deep sequencing, where we've integrated that data into this expansive clinical follow-up and characterization. So why would one look at a chemotherapeutic trial in the age of all these exciting targeted agents? Well, I think there's 3 reasons shown here. One, that chemotherapy remains a viable treatment regime in many countries in the world. The importance of genomic lesions, particularly in Cll4, is very similar to FCR-based chemotherapy trials, such as the German Cll8 study. And indeed, if one wants to identify clinically relevant biological subgroups, then one needs long-term follow-up, and that exists on these chemotherapeutic trials where it's not yet there on some of the trials of targeted agents. So the hope is that we can find key clinically relevant subgroups in Cll4, and we can go on to look at those in more detail in the context of these targeted agents. So this is a very quick slide to introduce you to the copy number landscape of CLL, and you'll be very familiar with the 4 copy number changes that exist there. However, much work has been done by many of the people in this room, and we now have a bit of a better insight into the copy number landscape of the disease. We're able to understand a whole series of secondary abnormalities, and this is a deletion of the short arm of chromosome 3 that we reported a couple of years ago, which used Cll4 data in that study and identified the methyltransferase SETD2 as an important target, and we know that SETD2 is important in cancer in general. So let's give you a little bit of an introduction to the mutational landscape of the disease. CLL has a simpler genome to solid tumors and further leukemias, with a median of less than 1 mutation per megabase. Though it's important to note that a proportion of patients are complex, and that's regardless of how you measure the complexity. That seems to be clinically very important. Chromothripsis was first identified in a patient with CLL, and we now understand the mutational signatures that underpin the molecular pathogenesis of the disease. There are at least 22 recurrently mutated genes, and this is really based on key studies. There is a lack of concordance between those studies, and that's probably to do with statistical power and the low prevalence of those gene mutations. But either way, these mutations cluster within key biological pathways. There are 4 genes, p53, ATM, NOTCH1, and SF3B1, that are mutated across all the cohorts in the literature at greater than 5%. We can understand whether these mutations are clonal or subclonal, and we have some insight into their temporal order. We can see how the tumors change over time, and this is very important, both preceding therapy and also the selective pressure of treatment. And we can define biologically relevant subgroups based on their genomics. And one good example is the structural features of the IGH locus, suggesting the cell of origin is very important in sculpturing the mutational landscape of the disease. And of course, we understand clinically what some of these lesions do, and we also can integrate those into established prognostic models. So let's go on to Cll4 now. This is a diagram of the 22 genes and the pathways in which they reside that we sequenced in nearly 500 patients from the Cll4 study. This is the heat map that we have generated, just showing you the prevalence of different copy number changes and gene mutations. Take-home messages from this analysis: about 1 mutation per patient, 95% had one copy number abnormality or mutation. The remaining 5% were mutated in their IGHV genes. There were 3 genes present in greater than 10%, 6 in greater than 5, and the remaining 13 were present in less than 5%. And many of these genes you'll be familiar with, and indeed this is very much the picture that one might imagine in a trial, in a cohort of patients of this type. Just identify a number of genes. EGR2 is downstream of the B-cell receptor. We went on to look at the clinical importance of these genes. I introduced EGR2 because this is the example I've chosen to show you for short progression-free and full survival. If we look at the data more holistically, and these are the genes involved with survival, and these are with progression-free survival. Lots of genes you can see there, the take-home messages. PFS and EGR2 associated with reduced progression-free survival, and 9 genes associated with OS. So 3 of the genes are 3 genes in the downstream of the B-cell receptor that are involved with MAP-ERK signaling, which we'll look at in a bit more detail now. So as I alluded to, each of these 3 genes is downstream of the B-cell receptor. When one looks at the relationship between these genes, then the key take-home feature is that, in principle, in about 85% of cases, these occur on their own and not with each other, such that in 12% of Cll4 cases harbor a mutation in these particular genes, which I think is a very significant number. Here is the overall survival of each of the genes in isolation. When we combine them, then you can see inferior survival, and then what you also see is that these genes are rare in those patients termed long-term survivors. And what we have is our 3 Kaplan-Meier curves here, and in a statistical model accounting for the confounding nature of all the biomarkers that exist, then of course these genes infer reduced survival, and there you can see the hazard ratio and p-value for those particular genes. Deletion of the ATM FISH probe emerged as a marker of reduced PFS and OS in our study, but ATM and BRCA3 mutation didn't. So we performed a stratified analysis based on the copy number status of 11q and BRCA3, as others have done. Here you can see the data. So what we've got is a coexistence matrix between BRCA3, ATM, and deletion of 11q. The 2 take-home messages are that mutations can occur with and without deletions, and the 2 mutations are mutually exclusive, suggesting that perhaps we have 2 independently biologically distinct subgroups of CLL. So we quantified the copy number status of BRCA3 and ATM, and we defined 5 subgroups for clinical analysis. Take-home message that if you have loss of the FISH probe for ATM, then you have poor survival compared to wild type, but it was BRCA3 biallelic loss and mutation that conferred the worst survival in our subgroup. And indeed, in a model that accounts for the confounding nature of the variables, the biomarkers in CLL, then BRCA3 loss and mutation was the second most important biomarker in that study. So I think there's a lot of evidence now that BRCA3 biallelic inactivation is quite an important subgroup of CLL. So perhaps one can consider cases thus. So we know that all patients will delete ATM, and perhaps 70 to 80% of them will lose BRCA3. We can superimpose the mutational analysis on top of that, and we can define our 5 groups such that if you have biallelic loss of ATM or BRCA3, you have the worst survival, intermediate for deletion alone, and if you have a mutation alone, then the survival seems to be the same as wild type. So let's move on to non-coding mutations. There's been a lot of work put into deconvoluting the complexity of the non-coding genome. Several key features have been found. I just wanted to mention quickly the importance of Notch1. We know that Notch1 is activated regardless of exon 34 mutations, and this is partially explained by a 3' UTR mutation, which results in splicing, truncation of the transcript, and protein stabilization. We wanted to show how important that was clinically. Here you can see our analysis of of the Cll4 dataset for PFS and overall survival. So we have our exon 34 mutations, our non-coding mutations, and regardless of whether you have a coding or non-coding mutation, then your survival is equally poor. What we then went on to do is to try and determine the increased prognostic power of Notch1 when you introduce the 3' UTR mutations. And what you can see is that when you look at the predictive power of Notch1 to predict survival events, it's significantly improved when you introduce non-coding mutations. So let's look at that all together. We put all our variables into a backward selection model based on a large number of both patients and events. This is the two models that we generated that account for the confounding nature of the different biomarkers that exist. Take-home message is that p53 mutations remain the strongest marker of reduced PFS and overall survival. We support the importance of EGR2, SF3B1, and those 3 genes downstream of the B-cell receptor involved with MAP-ERK signaling as independent markers of OS. And we show biallelic inactivation through deletion and mutation of BERK3 as an independent predictor of both outcomes with a hazard ratio second to that seen after p53. The last thing I wanted to mention is that it's been shown in retrospective cohorts that mutations beyond the resolution of Sanger sequencing confer inferior survival, but less is known about its importance in the clinical trials context. So we identified 55 mutations. We confirmed them for further technology. We curated their pathogenicity. We confirmed their VAF after adjusting for tumor purity. And we subdivided them into a Sanger positive versus Sanger negative group. We confirmed that there was no enrichment of poor risk biomarkers in either group that might explain survival associated with those two groups. And this is the take-home message from that study. Basically, those mutations that are Sanger positive, greater than 12%, associated with reduced progression-free and overall survival. But we weren't able to show that those mutations present in less than 12% were significantly different from those Sanger positive mutations or the wild types, suggesting that it's perhaps a group that sits in the middle. What we could show is that a subgroup of those subclonal mutations lower than 12% that existed concomitantly with a 17p deletion did do worse. So, in conclusion, hopefully I've introduced you to the Cll genome and put the context for the further talks you're going to hear about. The Cll genome harbors less mutations in solid tumors and acute leukemias, but these mutations do cluster within key pathways of importance to both B-cell biology and leukemiogenesis. Hopefully I've shown you the importance of the Cll4 trial in contributing to our increased understanding of the clinical importance of genomic lesions in CLL, and I've particularly taken you through an unpublished series of resequencing analysis of nearly 500 patients. But of course, we now need to go on and look at the importance of these in trials of novel agents, and that's what we're doing now in the UK. So each patient entering a UK clinical trial will have their whole genome sequenced, and we will feed in our observations from Cll4, but furthermore, we will use the whole genome sequencing data to infer all the different features of the human genome that we can from that data, and hopefully that will allow us to confirm some of the observations that we made in Cll4 and find new features of importance, both from a prognostic and predictive situation. So all that remains is to thank and acknowledge my group, my friends and collaborators, my funders, and you for your care and attention. Thank you very much.
Well, thank you, Dr. Strefford, for that wonderful overview through the eyes of Cll4. We have a few minutes for questions. There are microphones here at the front, so if you have a question, please come up.
I have a question, John, and it's regarding to a bioinformatic pipe that you were using to identify these mutations. Is it the pipe that identifies only sporadic acquired mutations, or one that also identifies germline pathogenic mutations?
Yes, I mean, it's a good question. We're very, very careful in the curation of our data sets. Of course, we don't have germline data on germline material on Cll4. That wasn't stored, that wasn't collected. But we're very careful using curation of databases and function, particularly around genes like ATM, which you know can be quite difficult to interpret. So we're very cautious, and we're very confident in the lesions that we found and the fact that they are somatically, the somatic changes in our cohort.
Dr. Rai.
I want to take this opportunity of thanking you for a fantastic start of IWCLL Edinburgh, and particularly the reliance that you have on some of the most important unpublished data, which is a great start of a new tradition, I hope. The question is that you have demonstrated that Cll4 is a treasure not only for what it was from the point of view of the original trial, but in subsequent decades continues to remain a source for molecular biology studies. But from this data, you demonstrate some retrospective power of some discoveries. Can those retrospectively identified mutation-based findings be used prospectively in planning future therapeutic trials?
Well, firstly, thank you for your question and your kind comments. Well, I think clearly biological pathways are being implicated in these subgroups, and many of them are relevant in the context of new agents. So I would imagine they will be important in informing the way we manage patients moving forward. So I think they are relevant moving forwards, but I do absolutely accept that the very successful therapeutic regimes have been developed in spite of genomics rather than because of it. I think we have to prove very clearly about the value of the genomics in teasing apart the biological drivers of these different types of disease. That makes sense.
Dr. Rosenquist.
So thank you, John, for an excellent talk. I was wondering the new findings with NRAS, BRAF, etc., were there any specific clinical characteristics? Do they carry any other poor prognostic markers? And also, could you see that you could have subclonal mutations, very low frequent ones, etc.?
Yeah, so obviously KRAS and NRAS are defined by being subclonal. Generally, I think Dan Landau and others have shown that previously, and we see the same thing in Cll4. We went to a lot of detail to check that there wasn't anything driving the poor risk in those groups. There's no evidence of any enrichment of any poor risk biomarkers. We see some trisomy 12s in that group, I think, again, as the Spanish have published on that. And we've just got a new tranche of Cll4 data that has come out of the paper, the banks of clinical information that has been stored, and we will begin to look at the association in a great more detail between some of those mutations and the clinical features that those patients had.
Thank you.
One more question at the back. Oh.
Should I ask or not?
Please.
John, thank you for your talk. I was wondering about these mutations with VAF lower than 12%. You showed there is no clinical significance. Was it the same across the group? Did lower VAF, for example, below 2 or 1% had a better outcome? And did you look for cytogenetic complexity in these cases?
We have limited whole genome copy number analysis data. We have mutational complexity data. The genomes were no less or more complex whether they were greater than 12 or less than 12% as far as their complexity. But the caveat is that we don't have expansive information there. There was no evidence of any poor risk biomarkers either established or inferred from sequencing data that we could see that might explain why the subclonal mutations the less than 12% of mutations weren't doing so badly. So the data seems valid. I think we've been quite cautious in that. Your other question was about the very low clonal mutations. So we haven't looked at those because we are concerned about the level of noise at the very low level.
We'll squeeze in one last quick question.
Thank you very much for this very extensive and complete work. In 2003, the Southampton group and our group first demonstrated the abnormal expression of AID in CLL. What is the role of this mutational enzyme in the mutational process that you have described? Well,
clearly the work of the Spanish group has begun to identify mutational signatures that underpin the molecular pathogenesis of the disease, and an off-target AID-type signature is present as a force driving certain ones of these certain types of mutation, particularly in IGHV-mutated CLL. And if one looks at the non-coding space, then there's clear evidence that those processes are at play, driving non-coding mutations close to genes that are important in CLL. So it has an important role to play in certain groups of somatic mutation.